Good afternoon. I know you're still arriving, but we have a lot to do in this session, so I'd like to make a start. I'm Mark Chataway. I'm the moderator of this session. I'll just briefly introduce our panel. The way we're going to hold this session is very informal discussions. So there won't be formal presentations. Some of our speakers may show you slides to illustrate, but it's going to be a series of informal discussions, and we're going to make you work early on. So after the first two informal discussions with our speakers, we're going to ask you to participate. So please be ready with your questions and your interventions. I think many of my panel will be known to most of you, but Dr. Soumya Swaminathan is the chief scientist of the WHO. She started as a pediatrician in India. She's a globally recognized researcher on tuberculosis and HIV. She was secretary to the government of India for health research and director general of the Indian Council of Medical Research. And she's published over 350 peer-reviewed papers or chapters. So, as always, it's a great honor to welcome Dr. Swaminathan. Dr. J.P. Sevilla, who is sitting next to her, is a research associate at the T.H. Chan School of Public Health at Harvard, a senior economist at Data for Decisions. He has a PhD in economics from Harvard, and he's worked extensively on the economic evaluation of vaccines, which is the point he'll be discussing today. Anne Boucher, who's sitting next to him, has been part of the European Commission since 1983 and Director General of DG Santé since October of 2018. Before that, she had responsibilities including structural reform and competitiveness, economic and financial affairs, which I think you'll see will be very relevant to our discussion today. She's trained as an economist and statistician and has a PhD in macroeconomics from the École des Hautes Études. Professor Lothar Wieler, who is sitting next to her, is the president of the Robert Koch Institute and has been since 2015. Before that, he was a full professor and director of the Institute of Microbiology and Epizootics at the Freie Universität in Berlin. And he's a member of the Strategic Technical Advisory Group for Infectious Hazards of the World Health Organization, among many other things. Next to him is David Loew, who is the Executive Vice President of Sanofi, the head of Sanofi Pasteur. Before that, he ran the Europe region for Sanofi and held a series of increasingly senior positions at Roche. He has an MBA from the University of St. Gallen. And then finally is Dr. Julio Mazzoleni, who is the Health Minister of Paraguay. He earned his medical degree with honors at the Facultad de Ciencias Médicas de la Universidad Nacional de Asunción. He qualified as a rheumatologist at Emory, and before becoming health minister, he was the head of rheumatology at the Hospital Central del Instituto de Previsión Social in Asunción, and is a former president of the Paraguayan Rheumatology Society. So you can see a very diverse and quite stellar panel. And I think it'll be a great discussion. And we're going to focus very much on the role of vaccines in strengthening health systems and in meeting the goals, the ambitious goals set by SDG 3. So, if I may, I'll start with you, Dr. Swaminathan. As the chief scientist at the WHO, you've been closely involved in the Immunization Agenda 2030. It talks about a world where everyone, everywhere, at every age, benefits fully from vaccines for good health and well-being, and talks a lot about life course immunization as a way to meet several of the SDGs. But at the same time, I noticed that document acknowledges that many of the targets set in the past haven't been met. So how will this be different? Why should we be more confident now?
Thank you very much, Mark, and thanks to the organizers. Perhaps if we can get the first slide on.
Do I know how to do this?
That's good. I think we have it on the screen.
Perfect. There we go.
So let me start with the question that you asked about why should it be different? Because as you know, we're coming to the end of the Global Vaccine Action Plan and the decade of vaccines. And this graphic actually shows what the successes were and perhaps what the challenges were and where we were not able to achieve fully. So while it did create a movement for vaccination, it raised awareness. A huge number of new vaccines have been introduced in many countries thanks to Gavi. Support to a large extent. In fact, one of the statistics that's often quite startling is that coverage of immunization as well as introduction of new vaccines has been much more in Gavi-supported, Gavi-eligible countries than in those without. So even the middle-income countries that are out of Gavi range have not been able to introduce the newer vaccines, which have come into the more lower-income countries. So there was a clear direction set. It was very ambitious targets. It raised the visibility of immunizations globally. So all of those were the good things. But perhaps what did not happen was that the movement was not sustained. The goals were so ambitious that most of the priority goals, strategic goals, were not met. And in fact, we've gone backwards on some of them, like on measles coverage. It lacked clarity on roles and responsibilities and accountability. I think it's nice to have a big a global agenda, but then ultimately who's accountable and who's responsible? I think there was no articulation of that. It wasn't very flexible, and there was a criticism that it was perhaps developed from not bottom up, but really came from up down, and therefore there was maybe limited engagement at the country level, and perhaps also perceived as not being so relevant. So an analysis of this really enabled us to move on to develop the Immunization Agenda 2030, which really is underpinned with 7 strategic priorities. And the first 2 priorities are really the basic principles of immunization as being an integral part of primary health care and the UHC agenda. It's not only an indicator of health coverage, but also an enabler. And if you do an analysis of the 20 million or so children worldwide who are still not completely immunized, and if you break that down further, 13 million children globally are zero-dose children, which means that they have absolutely no access to not only to immunization services, but to any healthcare services. So when you analyze where these children live and who these families are, you come across the same, they live in the poorest countries, in conflict environments, the most vulnerable populations, poverty, malnutrition, lack of access to health coverage. So immunization, when you reach these children through a health worker going in to vaccinate them, you also reach the mother, you reach the family, you're able to link them with health services. So that's really the way it's been articulated in the strategic framework as being very much integrated with and in a way enabling the extension of primary healthcare services to populations that don't have it. It's about the life course and integration. So traditionally we think about little children when we think about vaccines, but now we need to think about vaccines at different age groups. New vaccines that are being developed for TB, for example, would target adolescents and young adults, perhaps. HPV vaccine targets school-going children. So there'll be more vaccines coming into school age, and then also for the older age groups. We've seen serious diphtheria outbreaks among adults who've lost immunity. Of course, the flu vaccine is useful in adults as well. So we need to think of the life course, about vaccination during outbreaks and emergencies in humanitarian settings, and then about how do you sustain and scale, make sure that you have the enabling factors, the logistics, the supply chains. A big focus on data, and I think the next speaker will speak more to that. But really, countries need to now start making decisions, especially countries graduating out of external donor funding. There are many vaccines coming along which are not universal vaccines. So far we've talked about pneumococcal, rota, etc., which have been universal. We will now have malaria vaccines, TB vaccines, Ebola vaccines, things which are very relevant in some settings, not so relevant in others. So local decisions will have to be driven by local data. And then the research and innovation, I don't need to emphasize the fact that we need R&D not only on new vaccines, but also on, in fact, now we're thinking about even vaccines for non-communicable diseases. So I think science is really taking us forward rapidly, but also innovation in the way delivery is done. So we mustn't forget about the role of implementation research, again, in solving local problems and expanding coverage. The 4 core principles that the strategy has been informed by are really that it's people-focused, that it's country-owned. So there have been huge amount of consultations. I think more than 4,000 people have contributed to this. Over 100 countries have been consulted. There have been regional and national consultations. That it has to be data-driven and partnership-based. And if we can just go quickly to the next, and the vision, of course, is a world where everyone everywhere has access to vaccines in order to live healthier lives. And at a session this morning on antimicrobial resistance, the role of vaccines came up quite strongly, really the linkage between vaccines and preventing AMR. So I guess these are some of the things that are new, and therefore there's hope that this time around, there's, because of the co-creation, that there's more ownership of this, that there'll be more commitment at the country level, and that because it's grounded in the UHC agenda, which, as you know, last month, 193 countries signed up for at the UN General Assembly, that it would be seen as a way also of addressing inequities, considering that SDGs leave no one behind, and these 13 million children and the 20 million unimmunized children are the most vulnerable. They are the ones we need to reach. So I think getting to that will help us to also cover them. And a focus on systems, really, not just a vertical siloed issue, but a focus on systems. And I think just, yes, so this is just to perhaps show diagrammatically that immunization programs being anchored in UHC, and that, in the UHC index, which covers coverage protection and compares countries as to how they're doing, one of the indicators is the 3rd dose of DTP. And perhaps measles second dose might be even a better indicator for how well the systems are functioning. Immunization decreases costs of healthcare. The financial barriers to immunization are low, but it can prevent a lot of consumption of resources later on if children are. I still remember when I was in training in India, we regularly got children with neonatal tetanus, with diphtheria, with complications of measles, encephalitis, and so on, things which are very rare today. I mean, neonatal tetanus has been eliminated in most countries. But this was, 30 years ago or so, a regular feature in the wards. So I think we've made tremendous progress, but now we need to go on to the next level.
Yes, thank you. And I mean, I think this point you'll hear again and again our speakers talk about the importance of increasing access to vaccines as a way of meeting the goals of universal health coverage for the reasons you outlined, that it reduces demand, it reduces the severity of illness, it really has an important role to play. I just wanted to touch on one more point with you about R&D for vaccines, and especially you talked about Ebola vaccines briefly. You talked about vaccines which probably don't have a market in advanced economies, but are going to be very important in some resource-constrained settings. Are there things we can do to incentivize development of those vaccines?
So I think there's several things which can be done, and I think which are being discussed and perhaps will be discussed a lot at this meeting about what kind of innovative mechanisms to both create a push on the supply side, but also create a demand. This creation of CEPI is a good example after the last Ebola outbreak in West Africa. CEPI now was very successful in raising funds and funds vaccine development into the WHO priority pathogens, so mainly Ebola, Lassa fever, Nipah, MERS, etc. Also funding some epidemiological studies and the development of diagnostics. So I think what countries can start doing, and this I think applies to low income as well as middle income, high income settings, is get a better understanding of disease burden, because as I said before, more and more countries will have to take decisions based on data. So unless we know the burden of disease and the epidemiology of the disease, we would neither be able to do the clinical trials to test the efficacy of these new products. So if you get a vaccine for Ebola, for example, now Unfortunately, there was this huge outbreak in DRC, and so the vaccine actually underwent population-based testing. But very often you'll get a few cases, it's periodic, sporadic. You have to be prepared to do the studies when the outbreak starts. So preparedness in a research response is as important as preparedness to deal with the outbreak. And finally, I think countries also, middle-income countries need to be investing more in vaccines that would protect their populations from diseases that today cause huge number of deaths. Take tuberculosis. It affects middle-income countries as much as low-income countries, India, Brazil, China. So we need to see much more commitment from these countries into investing in R&D for vaccines for these diseases.
Thank you. And of course, it creates a virtuous circle, doesn't it? That if we know more about the epidemiology, then it's easier for manufacturers, for developers to understand the demand, to plan ahead, to meet it. Because, I mean, one of the points David will come on to is just how long the development cycle is for vaccines. You raised several points while we were speaking there, Dr. Swaminathan, about the economics of vaccines, which is what I want to move on to with Dr. Sevilla. You've spent a long time looking at this, Dr. Sevilla. Tell us, how do you as an economist, how do your colleagues in economics think about and quantify the impact of immunization, the value for money, if you will?
So economists, I'm sure everybody's taken an economics class sometime in their lives, and economists look at problems in one way. Economists see problems as always resulting at the interface of limited resources and unlimited needs. Yes, finite budgets and infinite challenges. Vaccines are no different. Vaccines are not cheap. A national commitment to vaccines, if you're not Gavi supported, is a serious financial investment. And so because budgets are tight, you run up against these budget constraints. But there are also these infinite needs. Money, every dollar that you spend on vaccines, you could have spent elsewhere in the health sector. You could have spent it on expanding the capacity of hospitals, building more rural clinics, improving cancer care. There are opportunity costs within the health sector. And so vaccines have to support their value proposition in the face of these alternative expenditures within the health sector. But there's also competition outside the health sector. If you're the Minister of Finance, every dollar spent on vaccines is something that could have been spent on education, on infrastructure, on clean technology, on cash transfers, poverty alleviation programs, pensions, and so on. And so vaccines have to prove their value for money relative to alternative expenditures within the health sector, but outside the health sector as well in just society in general. And so it's really quite critical for vaccines to represent good value for money. But that raises a question, which is, what is value? There are basically two answers to this question. The more standard sort of traditional question was, when you looked at the value of vaccines, you mainly counted things that happened within the health sector. Avoided mortality and morbidity, certainly that's very important. Averted medical costs, that's also important. But largely that was it. The value of vaccines largely had to do with stuff that happened within the health sector. The newer view says, no, you can't stop there. Health is just so critical to socioeconomic life in general that you need to start counting the stuff that happens outside the health sector. And so I have a slide that has some of these points, if you could just go through them. So one very important thing is education. Let's take pneumococcal disease as an example. For those of you who are parents of young children, you know when you've got when your child has an ear infection, they can't go to school. You know that you can't go to work because you're going to need to take care of them. Yes? So otitis media can result in impaired cognitive development. It involves a lot of school missed. The same thing is true of pneumonia. A lot of school missed. If you're unlucky and you get meningitis, Yes, you've got severe lifetime cognitive disability if you're unlucky. So pneumococcal disease has all these impairments that reduce educational attainment. You prevent pneumococcal disease through vaccination, you facilitate education. Second, productivity, right? So the loss of productivity in terms of work days lost in a typical high-income country over a typical seasonal flu year of season, flu season is in the hundreds of millions of dollars in euros. I've done some work quantifying the productivity losses of pneumococcal disease in adults in Denmark, and we compute that if you count the return to investment on the pneumococcal vaccine just on productivity grounds alone, that the rate of return is over 100%. You're like, is that a big number or not? Well, the return to the stock market in the long run in the US is 10%. The return to public expenditures in education in developing countries, it's roughly 20% on the outside. So a rate of return over 100%, that's a big deal. Yeah? Third, financial risk protection or poverty alleviation. Many of you know that in developing countries, and even in developed countries like the US, out-of-pocket expenditures are a huge cause of immiserization, a huge cause of households falling into poverty. You prevent the disease, you prevent the out-of-pocket expenditures, and you keep households above the poverty line. So work by Verghese et al. In India and Ethiopia shows that rotavirus-related out-of-pocket expenditures are seriously impoverishing, which means that part of the benefits of the rotavirus vaccination is, in fact, prevention of poverty. Next, fiscal impact. Americo Cicchetti and colleagues in Italy have started to measure the increased tax revenues that come from vaccinations that keep people at work. If you have fewer work days lost, you get higher earnings, and you get higher incomes. You get higher earnings tax revenues. If people are working longer, you have fewer social security payments which start kicking in to replace your income after about the 4th or 5th day of illness. And so if you simply look at the tax benefits and the reduced social security benefits that come from improved health from vaccination, they can exceed the vaccination costs. Finally, equity. One bullet point up, I mentioned that one of the important benefits is poverty reduction. Obviously, these benefits are concentrated at households who are very vulnerable, households who are just above the poverty line, which means that the benefits of vaccination tend to be disproportionately concentrated in poorer, less fortunate households. So vaccination is a pro-equity intervention. So this is the way that we think about it. And this is what's really critical here is broadening our notion of value and realizing that vaccines, they're an educational investment, they're an anti-poverty investment, they're an infrastructure, they're a productivity investment.
When you talked about productivity, you focused, as I think most of the discussion always does, on people in work. I know, though, that you've done I know that economists have looked at the impact of vaccines on the productivity of people who aren't in formal work, and that's as important, right?
Yes. So when vaccines improve the health of, say, for example, the elderly, you need to decide, okay, what are the benefits society gets from that? One of the classical benefits I mentioned earlier were productivity benefits. Well, you might ask, are the elderly productive? They're all retired, aren't they? Well, that depends on whether you have this limiting definition of productivity that's limited to paid work. But for an economist, what's important about productivity is, do you produce something, a good or service that's of value? It's a secondary issue whether that good is actually traded in the marketplace. Once you expand your horizons of productivity to include unpaid work in the form of housekeeping, caregiving activities, and volunteering, you suddenly realize the important contributions to national well-being made by the elderly and made, for example, traditionally by females or house spouses who stay in the home and work. And so to truly measure the health benefits of vaccination to people who are outside the labor market, you've got to expand your perspective of value and your perspective of productivity to include these things. Yeah.
And you mentioned vaccines that are used in adults, so you spoke a lot about pneumococcal and flu. I think that also applies to shingles and tetanus in your work as well, right? So it's quite a broad. Lovely. Let's pause for a minute before we turn the focus slightly more to Europe, which we will. But let's pause for a minute and see if there are comments, questions, disagreements from any of you. We welcome disagreements. So, you yeah, so we have, sorry, you need a microphone. Great, thank you. There we are. Oh, your sign fell down. Oh, my sign fell down. There must be a metaphor in this. Yes, well, I'm in good company anyway. Yes, sir.
Thank you, sir. I'm Dr. Mien Thuy, Minister for Health and Sports from Myanmar. I think the economic impact or benefits will be much more higher if we call EBI as EBI Plus program, which I'm going to do in my country, which means we will help educate mothers in terms of women's disease, menopause, CA cervix. For children, childhood diseases, what are the common causes, how to prevent them, and these will be incorporated in every vaccine session which will be conducted throughout the country. In that context, the economic benefits will be much more higher than giving ordinary immunization. Dr. Somia has mentioned EPI should be anchored into PHC. I should say more than that. EPI Plus should be anchored into UHC program, which will benefit a lot. Thank you, sir.
No, I think this is an excellent point. So the community education and health literacy of the community, we see today, vaccine hesitancy, particularly in the more literate and more developed countries rather than in the underdeveloped. So I think we need to ensure the right messages are communicated at every opportunity, and I think this is a very good approach. And that gives an opportunity to talk not only about immunization status of the child, but about other health promotion, both for the child and for the family, because the mother is really the gatekeeper of the nutrition of the whole family and so on. So excellent opportunities to give those health promotion messages. And that's been neglected as part of UHC. We tend to think about service delivery, and we pay less attention to the prevention and the health promotion aspects, which I think now we're realizing is really important.
And I think you'll hear that resonate in not just in emerging economies, but I think Dr. Vila will echo some of those themes as issues here in Europe. This gentleman sorry, was there one?
Yes.
One gentleman there, and then I'll come to you. Okay. No?
Yes, over there, please.
Sorry.
Sorry.
Thank you. I'm the regional director for the American Regional Office of WHO. Our region has had the greatest success in immunization programs. We've been able to eliminate polio, rubella, congenital rubella syndrome, measles up to a year ago, and etc. We have had the greatest success in the introduction of new vaccines. Very importantly was the commitment at the very highest level of government. Presidents were involved in our vaccination weeks that began as early as 2002. And the success also has been embedding them in the first level of care and in health systems. And through them, we've been able also to strengthen health systems and increase equity. I agree that you do need a bottom-up approach, but the top-down must meet the bottom-up, because you need the commitment of governments, you need the investment, you need an approach that will ensure that you understand demands and you understand the chain, etc., logistic chain. So the top-down and the bottom-up, extremely important, and extremely important the healthcare workers who must go from door to door, conducting the vaccines and following up. So wonderful opportunity. Thanks.
Do you have a microphone down there, Dr. Mazzoleni? Because I'm sure you're bursting to come in on that. Since we have a very convinced health minister from the region here, maybe.
Yeah, well, I was nodding as she was speaking. Well, we've had great results in America, and Paraguay has been an example of that through the cooperation with the regional office, and we're working on that and introducing those vaccines, as I'm going to outlay a little bit later, but definitely we have a commitment with that, and with primary health care, and the immunization program is an emblematic program within that.
And it has been that top-down as well as the bottom-up, right? So there's been a commitment from the highest level of policymakers to both coordination and to investment, as I understand it, right?
Absolutely, in terms of regulation, in terms of funding, protected funding, and also in technical advisory committees.
Thank you very much. This gentleman here.
Thank you very much. I'm a medical doctor, basically. I'm a brain physiologist and president of Kurdistan Health Summit. In my country, and I'm a media presenter as well, in my country, the access is perfect, the vaccines are available, but the problem is that the health awareness is lacking. So, for example, many times we have done many campaigns about, for example, polio vaccines. The people are finding some videos on YouTube that is saying the vaccine is not safe, so they refused. So the teams are going door by door to convince them to participate in the campaign, but they have refused. So I think we need to have a special fundraising dedicated to the health awareness in the developing countries, because we have all the facilities except the health awareness. Being a media presenter, this is very challenging for me, and I have the most popular health TV show in my country, but I couldn't convince all the community to participate in the campaigns or in the vaccination processes. Thank you.
Thank you. I mean, actually, Dr. Boucher, it's a perfect introduction to much of what you're going to talk about. So I think I might seize the opportunity, but it's a really, I mean, it's such a frustrating experience, isn't it? That you have a health system which is functioning, you have vaccines which are available, and then this disinformation gets in the way. And I mean, Dr. Boucher is going to talk about this from a European perspective, so maybe we should just move on to talking a bit about that, if you're comfortable doing it. I mean, I know within the EU, you've taken a very proactive stand. If you don't mind, I might just ask you to comment briefly before we talk about the broader issues on the action the European Union and member states have taken to try to combat disinformation, because this is not, as I'm sure you're aware, sir, a problem limited to one income band of countries. It's a problem we're confronting, especially in Europe and North America, I think.
No, you're right. I mean, that in Europe we have really this very, unfortunate rise in vaccine hesitancy. And that's why, the member states, they have decided a bit to join forces and to have, they agreed, in December 2008 on a set of core actions which they should be taking on vaccination to increase vaccination coverage, but also the issue of access and supply was in the back of their mind. And it includes a number of actions. It's extremely frustrating. What we have agreed at the European level is to monitor vaccine hesitancy and to monitor vaccine confidence. We have also committed to do a lot of behavioral research on it, which we are doing. But there are a number of actions which need to be taken. True that the information on vaccination is not always easy to access, and we have now agreed that to have a single point of entry with our Center for Communicable Diseases on information on vaccines. what we see also, for instance, when we ask about vaccine hesitancy, I mean, and we ask people, why do you vaccinate? Then they often say, because the doctors told me to do that. And when we ask, why don't you vaccinate? We often get this reply that because no doctor told me to do it. Yeah? So the health professionals are extremely important in recommending and encouraging vaccination, and we have created this vaccination coalition where we try to work with all the segments of the health professionals, the doctors, the pediatricians, the nurses, the midwives, the pharmacists, and so on. I mean, because it's true that they are important actors for vaccination policy. But, and of course, I mean, what is really vaccination skepticism is not the largest part, but it's a very toxic part, and it needs to be constantly fought because it could increase. So, I mean, we have a number of debunking actions as well on this, but it is an effort of every moment, and it's good that the member states have understood that they had interest to do that jointly.
And I think it's such a powerful point you make that often doctors underestimate the impact of their personal recommendation. Patients do respond. Let's turn to the broader issue, if we may, of what the European Union is doing, because the Union has taken a very proactive stand on immunization, I know. We can only touch briefly on it, but the Global Vaccine Summit, which the Commission and the WHO organized together, happened recently. As, of course, did the outcome of the UHC meeting, which Dr. Swaminathan referred to. I was struck. A background paper for the summit said that at least 14 of the 17 SDGs, accomplishing those, is linked to successful immunization. So tell us a bit about what the Union and what European countries can do to push the political will for successful immunization.
I mean, when it comes to communicable diseases, we think it's a global response. I mean, European Union is not enough on its own to combat the disease even internally. And the way, I mean, so for us, I mean, global commitments are extremely important, and we push for this. I mean, health diplomacy is not light activity. You really get commitments through this. You have a global framework. I mean, the SDGs are useful. The universal health coverage is a big anchor for vaccination policy, and it's for us a framework which are important. But on that basis, once we have the political commitment, and we were talking of the top-down, the way we promote and we honor the commitment is by putting our own house in order. And the recommendation I was referring to between the 28 member states of implementing vaccination strategies is one of the aspects where we address the specific European problems. And then we do it through our international tools and our development policy. I mean, we're quite active with Gavi, but we are also through our specific development programs. And for instance, I mean, sub-Saharan Africa is a very important target area for Europe and the neighborhood and the Mediterranean countries where we are important donors. I mean, if you look I mean, in the last, I mean, between 2013 and 2017, we have contributed to the immunization, full immunization of 13 million children. So it is an important component of our aid. And then the last pillar of our action is research. I think it is important. You highlighted it as a general strategy, but I mean, it is a contribution for the development of vaccines. And I mean, we referred to the Ebola vaccine, where Europe played an important role. But if you look also right now, we have a lot of research funding going on for candidates for tuberculosis vaccination. So these are extremely important areas of actions as well.
So things that potentially have an impact within the Union and then around the world.
Beyond the Union, yes.
Dr. Vila, I know you have lots of global links, but let me ask you to focus a bit specifically on a national perspective, because obviously you have this detailed overview of Germany. I mean, even here, in a rich, highly advanced healthcare system, there are lots of barriers to immunization. And how can we, one, overcome them here, and how, two, can people who come from countries which are rapidly developing their healthcare systems learn from the mistakes we've made in Europe?
Yeah, thank you. Well, actually, I think most of these answers have already been given. But let me tear it down to specifically to Germany. It is really important to understand that in Germany, vaccine hesitancy doesn't have a big influence on the vaccination rates. There are investigations on this, and this is a very, very important information, because if you don't know the root of the problem, how can you decipher it? How can you solve it? And it has been an ongoing narrative for years that in Germany the anti-vaccinists take place and are the most important reason why we don't get the rates done. This is simply not true. But we could only prove this because we did investigations in our own country. Yeah, that's a very, very important point. If you take data from other countries, it's different cultural backgrounds, it's different health systems, so you cannot just easily transfer these data from one country to another. I think this is very, very important. And secondly, in Germany, we have a very advanced health system. However, as already was mentioned, medical doctors are at the basis of it. If medical doctors take their duty, it's basically done. Yeah? But so then you ask, why don't German doctors take their duty? And they don't do it. But the reasons are barriers that are purely technical mostly. It's one big barrier in Germany it's a health insurance system. The reason is that different specializations, like pediatricians, for example, or internal medicines, or you name them, they are not allowed to vaccinate other groups of the population. A pediatrician can only vaccine kids. But kids, for example, 1-year-old kids, they usually don't go alone to the doctor. Usually they come with their parents. And these parents are in an age group that, for example, is one of the age groups that we have deficits in measles vaccinations. So the easiest thing would be that the parents would be vaccinated. However, if the pediatrician does this, he will be filed to pay for this, for example. So yeah, it's a very easy, a very primitive technological problem. And now, finally, after years and years, we hopefully will solve this by new legislation, so that each and every specialist is able to vaccinate a partner that is on board, which is a very, very easy catch. So this is only due to some insurance interventions based on financial incentive. Yeah? But secondly, in Germany, we have tremendously reduced the local health authority resources. So basically the public health authorities on a local base. So we don't have any of these possibilities to go into schools, vaccinate, do active vaccination. And this isn't done in Germany because these local authorities have been run down with their personnel. So this have nothing to do with a good health system or good hospital system, inpatient system, but these are very, very easy barriers which nobody took care of for years. And so these are the barriers, if you lift them, we can easily get the rates done. I'm very optimistic when it comes to this. But this you have to know. If you want to file a recipe in a particular nation, in a particular society, you have to identify the problems, and then you can be able to solve them.
I was really struck by something you said to me when we spoke before, that the average, if I understood you correctly, that the average German adult sees a doctor 26 times a year. Is that right?
Yeah, they like each other. Yeah. You know, these are data from the German medical journal, Deutsches Ärzteblatt, 25 times a year on an average. Of course, there is a tremendous bias due to age groups, but on average. So how is it possible that they don't get vaccinated? It's because, among others, there is not too much incentives for some of the doctors. I told you one of the reasons, but another reason is actually I don't have the true data, but most of the medical doctors, they don't ask you for your immunization status when you go to them for the first time. And this, of course, could be easily solved if you have a digitalized patient database. You see whether this guy or this woman has been vaccinated or not. Technologically easily done, but it's not done in Germany currently. So the doctors don't take their duty due to some lack of incentives and due to barriers that have been set up by the system.
And if the system worked better, I mean, I realize this is a slightly mixed blessing, but is it possible that Germans would see the doctor a few times less per year?
This is now a question for an economist, among others. I'm fully convinced that it is possible to visit a doctor less often. Yeah, we have 20 million people inpatients, 20 million inpatients every year in Germany. We have 83 million population. So it's a high rate, isn't it?
Wow, that's great. Let's take some questions. I can see a lady here has her hand up, so if we could come to you. And then I can see a lady right in the back there.
Thank you. My name is Fumi Adewara, and I'm the CEO of an integrated telehealth startup focused on Africa, trying to bridge the gap in shortages of doctors, providing a fully integrated platform, connecting them to about 100,000 doctors globally. My comment relates to the issue of hesitancy, vaccine hesitancy. And I think that telemedicine has a very important role to play in this aspect in terms of addressing the doubt and the misinformation and misconceptions. And in a highly scalable manner, you can provide health education to patients, to healthcare workers in rural areas through virtual means. As well as the use of SMS messages has been shown to provide increased uptake in rural areas at particular times when children probably are approaching their milestones. So I think we need to leverage more on this to increase vaccine uptake. Thank you.
I know Dr. Swaminathan wanted to come in on another point, but I think there's been a lot of work on that in India as well, hasn't there, using messaging?
Yeah, I think we have to test different methods, but I also wanted to respond to previous question on social media. I think social media plays a huge role now, particularly I think the younger generations are really influenced. So recently, WHO has entered into an agreement with Facebook and Pinterest, and we're also working with Twitter now, where if someone does a search for immunization or vaccination, they get directed automatically to a site which has authentic information. So it would be directed to the CDC website, for example, if you were in the US, or to the European CDC if you were in Europe, or to the WHO website, rather than go off to a dubious information source on vaccines. So both Facebook and Pinterest have already implemented that. I think we should test that out and see. And the other thing is, I think the local key opinion leaders are really important, whether they're religious leaders or other kinds of leaders. So I know that in India, Pakistan, and many countries, the involvement of the local religious leaders in spreading the message of the importance of immunization has been quite important, especially our experience with polio showed that, that helped to remove barriers.
Yeah. Yes, absolutely. And I think also it's worked in Ebola as well, absolutely. Great. There was a lady in the back there. Yes.
Hello. I'm a PhD student at Karolinska and in Stockholm. And when thinking about EU countries and how they are handling the vaccine problems around the European Union, like you could see Italy that made mandatory vaccines just recently. And now Sweden is also thinking to go, like they're discussing that in their political agenda, and other countries are implementing a lot of fines, really expensive fines. So isn't it maybe this run to meet the SDGs goals or these health outcomes sort of making the country make wrong decisions, like imposing like vaccines, and then that's having actually the complete opposite effects in the population? Like, why are you imposing that on me? So should we make them mandatory or not? Is it working really on a longer term?
Now that is a very interesting question. Does anybody feel like tackling that on the panel? I mean, I know the Italian example has gone through several stages, so would you?
I think it's a very sensitive question throughout the European Union, and it's very clear for us that there's certainly not an EU position on it. Don't expect me to tell you what to do, but I mean, vaccination has to be driven by epidemiology and risk basis, yeah? So if you look, and then afterwards, I mean, like it was explained, I mean, you need to understand exactly what motivates people to vaccinate and when it is needed, and you can find different systems without having it mandatory. Certainly, when we had the discussions within the European Union on what should be done and the core elements on which they agreed is that they should all aim at having 95% of coverage for measles for children, yeah? And that is the common, how you reach it. There are different ways. You can organize vaccination in schools. You can organize the pediatricians or the doctors to do it. They have chosen different ways. Mandatory is certainly not the standard way.
Dr. Sevilla, you come in on this. Do you want to come in on this? Did you? And then, are you going to touch on the sort of nudge theory? Because there's a middle way, isn't there? That you don't make it mandatory, but you make it more complicated for parents to avoid immunization than to do the right thing.
The nudge theory is not part of my expertise, so I may not speak to that. But it is fairly clear from US experience that when you expand opt-out opportunities based on religious belief or libertarian political commitments, then you're raising the risk of measles outbreaks. That seems very, very clear. It happens on cruise ships, it happens at daycare centers, it happens in shopping malls, it happens at Disneyland, and so on. So it is really quite important here to emphasize that there are empirical aspects to this question, but there are also normative aspects. Right? You want the central normative question is that you need to balance the public health with self-determination of each parent or each child or each adult. But there's also the empirical question. It is possible, it's not out of the question that mandating vaccines sometimes occurs. It'll sometimes be perverse. It'll have the opposite outcome, and it's basically a matter of context which effect wins out. But I do think it's important to remember that there are these empirical and ethical issues embedded in this one question.
Professor Villa, did you want to come in on this or no? Okay. Dr. Mazzolini's alma mater. I'm not going to make you comment. I won't put you on the spot. But they have an interesting practice at Hopkins that nurses who won't be immunized are forced to wear a badge all winter, who won't be immunized against flu, are forced to wear a badge all winter which says, "Warning, I haven't received a flu vaccine." As I understand it. And apparently it's had a miraculous effect. Yes, sir. Yeah.
My name is Paolo Villari, and I'm from Department of Public Health and Infectious Disease at the Sapienza University in Rome, in Italy. I don't want to say if I'm for, towards, or against mandatory mandatory but I have to say that the legislation in Italy was very effective in the sense that I mean the immunization rate for children is very, very high. I wanted to say that even if before the introduction of the new law there was a sort of increasing the trend, but however, no doubt about the fact that I mean the immunization rate increased in 2 years at very high level. Not yet at 95% level, but we are very, very, very close. There is an important communication problem because in spite of this increasing immunization rate, measles continue to be in Italy, but it's very clear from the epidemiological point of view because there are many people at the middle age without, immunization or natural immunization. So I mean, the measles continue to spread in Italy. And there is an important problem of communication because the population thinks, okay, vaccination is not effective because even if we increase immunization rate among children, measles continue to spread. I think that this is an important problem of communication.
And something Professor Vila was emphasizing, the need for doctors to check. Let me try and get one more comment in from this gentleman here, and then we'll move on to our last two panelists. So this gentleman in the front row here, please.
Hello, thank you so much for the discussion. I am a doctor and also a European public health student at the French School of Public Health. I'm specializing in epidemiology and biostatistics. Earlier on, Sumia mentioned about the role of medical doctors in implementing this increasing or improving vaccination coverage. From the sub-Saharan Africa, as we all know, the workforce, the health workforce, it's quite limited. We don't have as much as we should, unlike the other developed countries. So what can the sub-Saharan Africa learn, sub-Saharan African countries learn from the developed world in terms of how to use the health workers, the doctors, to improve vaccination coverage? Thank you.
Well, I don't know whether we necessarily have to learn from the developed world, but because the model is different. And as you said, in many countries, there are few doctors, and they're mostly in the hospitals, and then you have nurses or just community health workers. But in a way, nurses and community health workers are often closer to mothers, closer to the community, and because they're part of the community. And there's, in my experience, there's always less of a gap, less of a distance. And so what they say actually could have much more impact. And they also become living examples. So if the community health worker, is vaccinating her own children, her family members, she meets members of the community in social situations as well. So I think that the element of trust and confidence building is very important in this, and that probably is why many of those countries we've seen have actually achieved very high immunization coverages. So I think the countries that haven't done so well are because they've had conflict, they've had mass migration, they've had other crises, and because of which the health systems really haven't been functioning well. The other thing is the use of digital tools and technologies now today offers the opportunity that even if you're a health worker in a remote place, that you would have access to latest information, and that someone mentioned telemedicine, that you could be connected up with a doctor in a hospital in a city somewhere where you could ask for advice. And I think we need to move much more rapidly to use digital technologies more effectively to empower our health workers.
Professor Vila.
Yeah, just two ideas here. First of all, don't over-regulate your health system, because you will be stuck in many decision-makings afterwards. This is perhaps the most important topic I wanted to raise. The second is always keep the look on the patient's needs, and this may prevent from some developments that you don't want to have in your country.
Must be one of our key takeaways, regulate at your peril. Let me move on, David, if I may, to you. We've already touched a lot on the contribution of vaccines to health systems, but do you feel that sometimes we are still underestimating, we're still undervaluing the impact of vaccines? And if so, what can international actors, what can countries do that might change that? What can they do differently?
So, yeah, the answer is yes, I agree with that statement. I think we have a lot of information now which shows that vaccination is the most effective intervention after clean water yet it's not really reflected yet in all the countries. And we just had a discussion before we started the session in all the budgets yet of the countries around the world. When we look at how much we invest in vaccination, typically it's below 0.5% of what goes into healthcare spend, yet contrasting this with the fact that we know it's the most effective intervention, it doesn't seem really to square. And sometimes this happens because the budgets are in silos and they cannot be moved easily inside of a healthcare system. So that's probably root cause number one. Root cause number two, I would say, is how much information do we have beyond that when we dig on different diseases? So we have heard from Professor Sevi looking at pneumococcal vaccines, there is data now which shows that it can also reduce antibiotic resistance. We have seen the same thing on flu vaccines. It can reduce 67% the use of antibiotics when we have high vaccination rates against the flu. And we know today that antimicrobial resistance is one of the biggest threats to human mankind. I mean, this is an instrument, antibiotics, that were developed and which has been really a blessing for mankind in terms of lowering death cases. But we see antimicrobial resistance starting to become a bigger and bigger problem. So we should really leverage the weapons that we have today, which is increase vaccination rates on some of these vaccines, which can help have an impact on the use of antibiotics. I think we have heard about the conspiracy theories, of course, and the confidence in vaccination, but we did a study as well looking at what do governments do which have the highest vaccination rates. And we did that on flu vaccines, and we're going to shortly submit this to the Lancet. What we have seen is that the countries which have vaccination rates of 65% of the target population that should be vaccinated, so typically, very young children, then of course the elderly, frail, but also high-risk patients, which, for example, are diabetics or asthmatics or people who have COPD, etc. They have a whole battery of things that they're doing. So it's not one thing that they're doing. They have a whole battery of things. I mean, it starts with, and we have heard this from Professor Wheeler, giving a real incentive to healthcare providers, a financial incentive. And it needs to actually be quite a significant one, because if not, people are not doing the efforts of, vaccinating perhaps not just the child, but also then at the same time the parents. It's also make it easy on people to get the vaccination. We see now a movement where in the US, we have 50% of people who get the flu vaccine go to the pharmacy. They walk into a CVS pharmacy and they walk out and they have the shot. So it's really that easy. In France, we had a situation before where people had to go and see the doctor, get a script, go to the pharmacy, get the vaccine, go back and see the doctor, and then get the shot. So clearly the new health minister has recognized that this is a significant problem and has completely changed that practice now, luckily, and has started to allow pharmacists also to vaccinate. Last year it was a pilot project. This year it's in whole France. I know that Germany is also discussing that. And of course, you're confronted with sometimes a bit of feedback from doctors saying, no, we don't want the pharmacists to vaccinate. But I think we have to get over these kind of internal discussions of like one profession against the other profession, and sometimes it's linked, of course, to remuneration, to really make sure that we hit these goals of high vaccination. We also know that governments need to spend quite some effort on making people aware what are the consequences of these diseases. We know that if you don't vaccinate against the flu, you have a much increased risk to have cardiovascular complications and even heart attacks. So flu vaccination can prevent the same amount of heart attacks as lowering of cholesterol or, for example, antihypertensive therapy. It's new data that we have found and which have been published. So there are some collateral effects that can be protected if we have higher vaccination rates. So the last one, and that's also an important one, are often the procurement systems. Often many countries are trying to buy vaccines through a tendering system, and it actually comes in a pretty big contrast because when you have tenders, you don't know, are you going to win a certain quantity of vaccination that you can sell or not? And it takes 2 years in general to produce a vaccine. 70% of that production time is passed in quality control. And that contrasts with, if you have a tender just driven by price, that then for the industry, it's extremely difficult to predict, do we actually want to produce that or not? Because if you produce it and then you don't win, you put it into the bin. And of course, that doesn't make any sense. It also drives down prices quite significantly. And the consequence, what we're seeing is that we only have 4 large multinational companies left in the vaccine space. That's not very logical, because we all need worldwide a large amount of vaccines, and we need the industry to be able to operate in an ecosystem which is healthy. Novartis has left the space very recently. Baxter has left the space. So something where we have to ask ourselves, is that the right way to go? Or should we, if we continue tendering, change the procurement practice to value also the reliability of supply, for example, the value that the vaccines are providing, and so that it's not just all about short-term price decrease. And in fact, Germany has abolished tendering and has seen a significant amount of more vaccines coming now into the country.
We've touched a couple of times, a couple of comments from the audience, and Anne touched on the importance of digital health. I know that you see a great potential here to assess the impact of immunization, but you also see some obstacles, right? And I think, yeah.
Yeah, I think, we are living in a digital world nowadays. And I think we have, in the healthcare system, not yet fully leveraged the transformative power of digital, and especially of electronic medical health records. Of course, protecting patient data is very important. So it needs to be anonymized, and the technology today allows us to do that. Now, when we think about these electronic medical records, they allow us to run scientific analyses on these electronic records. And I give you an example. We have a database called Darwin, where we have 300 million data records from clinical trials that we have prospectively conducted, but also from real-world effectiveness trials that were retrospectively conducted. So this database allows us now, with machine learning and artificial intelligence, to see correlations. And I can give you an example. We looked at what happens in diabetic patients when they have flu, and what happens if you get flu vaccination rates up. What we see is that you have not just a better protection against the flu disease itself, but you also have massive effect on complications of diabetes. So there are these collateral effects, and having these large databases and electronic medical records allow you to find these correlations. So this is now a retrospective comparison. We are now doing the next step, and we are doing prospective comparisons with Kaiser Permanente. That's a health maintenance organization based in California. We are comparing 2 vaccines in 1.6 million patients prospectively over 2 seasons. We're doing the same thing with the Nordic group. They have just put it on clinicaltrial.gov with the Finnish group, where also on electronic medical records, we are randomizing also 2 groups and comparing 2 different vaccines over 2 seasons in 68,000 patients. Now, you can imagine that these numbers far exceed what you can do in a normal standard clinical trial. And so I think our challenge today is, and we discussed this with Madame Buchet, is to go towards a harmonization on an international level of our electronic health records. If we manage to do that, we can run multinational trials over very large sample sizes, and not just doing that on the flu, but on many, many diseases. You have a lot of chronic diseases where having these kind of prospective trials are going to be a fantastic tool to see what we need to do to improve the healthcare system. And what does it do? It makes the healthcare system more efficient. It makes the interventions more efficient. It allows to collect more insights, scientific insights, to academia. And it also allows the industry to run trials in a much more cost-effective way on much larger sample sizes. So it's really a win for everybody, and of course the most important one for patients and people living around the world, having more sustainable healthcare.
And as the point of this session, as we extend coverage to ever larger numbers of people, it becomes really important to have that efficiency. Dr. Mazzoleni, you're the front end of this, so you're the one who's responsible for doing exactly that in Paraguay. And it's interesting that you've chosen to implement, I think we have a slide somewhere, which I'll try to get up. You've chosen to implement a very high number of vaccines within your universal immunization program in Paraguay. Although Paraguay has a lower per capita GDP than some of the countries that aren't colored in for every vaccine on this map. Why did you take that decision?
Well, as Mr. Sevilla was pointing out, limited resources forces you to allocate them where they have the highest impact. And you have to do them not only based on cost effectiveness, but also sometimes with a lot of creativity. So we've been working on that, and there are very good results that we are receiving lately. I think that decision is also based on the fact that we have to also protect a very fragile health system, a system that has in the primary level only 40% coverage that we're working on improving. We also have a rate of 0.8 hospital beds per 1,000 patients. So in fact, we do need to protect that health system. And we have a situation in the country where we have a lot of dispersed population, vulnerable population, such as indigenous population in areas with difficulties in access. So I think that the decision, it's seen as good because of the historical rates that we have been able to drop in terms of illness and deaths. We've come a long ways. In 1980, the National Immunization Program was installed, was created with 4 vaccines and tetanus toxoid. Ever since, we've been including other vaccines such as anti-pneumococcal vaccine. We have a rotavirus vaccine. We've also included an HPV vaccine. And lately, coinciding with the recent announcement of the eradication of wild poliovirus 2, we are including the second dosage this month of the inactive poliovirus in our schedule. That has been a big investment. I think we're close to 3% in terms of the budget, and we'll continue to do so based on cost-effective evaluation. In 2012, we've also passed a law that ensured that we had a mandatory vaccination of these vaccines included in the national program. We also have protected financing from the budget, from tax revenues for this program, and we've appointed members of intersectorial technical advisory committee. So everything is protected, and although we haven't been able to do such a detailed evaluation of how this done, it's been done based on cost-effective models that were provided through PAHO. We've made those decisions. One of the things that we need to improve, however, I think there's some numbers that we can. This is the Americas.
And by the Americas, we mean Latin America.
Latin America mostly, yes. PAHO, and I think we might have another one, but basically yes, that's Paraguay. So we've been able to eradicate polio. We haven't had measles cases in over 2 decades. We don't have rubella or congenital rubella syndrome. So there's a lot of effort being placed on preventing these conditions that are through the vaccination program. And as I was saying, one of the things that we need to improve, however, is to get the data from the terrain in terms of how much morbidity has been impacted. We have some problems with that due to sample size of our studies and also due to a rather incipient digital information health system that we're developing as we speak, but we're below 10% of the whole system by now.
You said I know that Paraguay is also working with other countries in Latin America, and there's been a very high level of regional cooperation. I got you to touch on this briefly earlier, but we read so much about the refugee issues currently in Latin America. Can you tell us a bit more about how you're collaborating specifically on that?
Sure. Let me point out a little bit, or first, rather than we are trying to advance decisively on a model towards a health promotion model and a prevention of diseases model. So that's why we're so focused on vaccination. And we've embraced primary health care as the strategy to do so. And we feel that vaccination is an emblematic program, and it allows us to go along with this. Not only this, but it's also a platform for our social services, our protection services. For instance, we have a social program to fight poverty that is based on cash transfers. But these cash transfers are subject to complying with certain things, such as vaccination, an updated vaccination card, and also maintaining school attendance. The other intervention that's worth mentioning is the one you were asking about, particularly that has to do with transnational efforts in the borders to fight against the threats of measles and yellow fever, in particular in our region in Mercosur. And also to have some regulatory agreements in terms of vaccination. We're facing common challenges, such as the diseases I was telling, but also emergency and disasters. Paraguay has just come from a very big flood. We've had fires too that you've probably seen all over in the region. We need to increase our vaccination coverage. We have some problems with supply, and the forced migration for political reasons in the country that really pose a big threat in terms of conditions such as measles and others, as we were saying. So we're working on all of that, and I think this initiative with Brazil, with Argentina, has been very effective. In fact, it has been for Paraguay. The initiative has taken place for about 2 weeks in our neighbor countries, but we have extended them to a month, and we've reached 90% of the susceptible people in the borders. So, for instance, Brazil has most of its cases in the state of Sao Paulo, a very populated state, but some of those cases are in the state of Paraná, which is right in the border with Paraguay. So, although we haven't had cases in 20 years, the threat is very big at this point, and I'm putting every effort in trying to avoid that.
Great. We have about 10 minutes left, so let me try and get some people in. Can we get a microphone to that lady conveniently situated right in the middle? We're trying to make you work hard. There we go. Lovely. Thank you.
Thank you all, and sorry for my lack of foresight in sitting in the middle. My name is Anu Dethan. I manage the health sector at the Jameel Poverty Action Lab, or JPAL. Thank you all for this fascinating conversation. One question I have for you is, we've been talking about uptake of the first immunization, but we also see that over the course of the vaccination schedule, there's also often a very substantial drop-off in uptake. And one of the driving factors behind that can be more behavioral, so parents and guardians fail to persist in bringing their child back to the clinic. So in all of your discussions and developing the action plan and things like that, I was just curious whether you've touched on this aspect and whether there are nudges, incentives, and other things that can be implemented to improve the uptake over the course of the entire schedule. I've seen some studies that hint that these sorts of incentives can increase vaccination pretty substantially, so I was just curious about that.
Dr. Mazzoleni, have you done any research on what the impact has been of you mentioned tying the poverty reduction payments to full immunization. Is there any research on what whether that's had an impact on stopping this reduction over the course of the course? Sorry.
Well, we have some problem with sample sizes, as I was saying lately, but we do see an important effect on that respect. And we also are working right now on incentives for regional hospitals and their political governments in terms of achieving certain health goals, such as vaccination coverage, in order to provide them more money if they achieve the standards are taken into account.
I mean, I know it also ties very much back to what you were talking about, Dr. Vila, that it's not simply a question of incentives, it's a question of making sure the structural barriers don't make it really difficult. Because I think you said fail to persist, but your point was that it's often, despite the system, the parents persist. Anybody else want to come in on that? Or?
Quickly, I mean, we think the vaccination card is something very important, and if it's digital, even more important, because, I mean, again, when I refer to the research which we do on vaccine hesitancy, I mean, lots of the response we get, which are people think they don't need vaccination, that it's for children, that apart from the fact that, I mean, doctor hasn't recommended anything to them. So if that was very clear that, I mean, they would know about the vaccination schedule and when they need to go back to the doctor, that would be very helpful. And we think also at the European level, given the mobility we have, it's good that people get this idea of having a vaccination card with which they can really travel and move between countries, because countries have made different, very different choices on vaccination schedules in the different member states.
But having that record, yeah, allows a health professional to see, yeah, absolutely. Gentleman there, yes.
Yep. Hi, my name is Mujahid. I'm a professor of health governance at the Hertie School. So I think in certain societies, it's not so much about vaccine misinformation or accessibility issues, but more about parental investment, time investment, or financial resources investment towards certain genders. So what I'm talking about is gender inequality in terms of vaccination and bias. So certain societies have stronger son preferences and want to allocate, resources towards them. So do you think there is value, or is there evidence that has shown that there is value or social value for vaccinations for women more than men in these societies? And what are the strategies that have been used to tackle these issues?
Have any of you looked at this as an issue? It's a fascinating question.
We haven't really investigated the issue, but when we have the coalition for vaccination, we talked a lot with the midwives who said that they were aware that the women do not have systematically access to vaccination. But they say the time we have is so short and we have so many advice to give that it's very difficult to be able to channel information at that time.
Just a small comment. Paraguay is a very matriarchal kind of society, so most of our public policies are focused on women. And they're much more effective.
Yeah, I know. It's, we have to apologize on behalf of our gender so often.
I think this raises another important issue of looking at the data disaggregated by gender. And this year, the World Health Statistics report really tried to disaggregate by all the data by gender. And what we found was that it basically very difficult to do that because a number of countries not reporting data that's disaggregated. So I think important to build that into the systems. And the other quick point I wanted to make is really about empowering the community health workers and the people who are doing the vaccination with the data that may be sitting somewhere higher up, but which hasn't really trickled down. So the person in the village really needs to know which households are the ones who are missing out on the vaccination. To follow up on the vaccination card issue, it's no good the card just sitting in the health center, but the information needs to go back down to the health worker in order to persuade those families to come back.
I'm going to be ambitious and try to get one more question in. So, yes.
Thank you very much. Dr. Santucci Nechada, I am the CEO of the Women Brain Project, and I am particularly pleased to hear this comment about considering sex and gender factor when we design health solution. So we are leading an unprecedented discussion with the scientific community, policymakers, government, to understand where differences, any type of diversity actually, do have an impact on clinical outcomes and any type of health outcomes which is relevant for patient management and for access to health. Women, for instance, when we speak about digitalized solution, do have a much less access to the digital world worldwide. And this was the report according to the I think it's called Smartphone Report for Women in 2018, which was published. So what are we doing about it? This is a call to the whole scientific community. When you do your science, please power your study accordingly, report the data by sex and gender, break down the numbers, and try to make sense of what it means, differences of any type. Otherwise, we will keep repeating the same type of mistakes again and again. It was 2 weeks ago, and then I finished my intervention, where we have had the first drug approved for men only for HIV prevention. And this should not happen. Basically, women were not included in the clinical trial design. This is what, in 2019, we can't sustain, we should not accept. Thank you.
And I think everybody on the panel will just nod. That's a wonderful point for us to end on. Thank you so much. I don't think we could have designed a better ending than that. I think the bright point of what you've said is if we link back to what David was saying earlier about the potential for digital health to really be much more inclusive and have much better samples. But it's a wonderful point. Thank you so much. Been a great discussion, and I leave wishing we'd had more. So that's a success in my book. Thank you very much.